So that's why this is why we're trying to detect our patients in the early stages of the infection, so we at least eliminate the Hep C virus and they have a normal and healthy life. When you look at what are the chances of someone with hepatitis C infection developing cirrhosis or liver cancer, there's several risk factors. So being a male is one, being older is another one, drinking alcohol is another one, and that's why we always recommend people with chronic hepatitis C or advanced liver fibrosis to stop alcohol use. And then having a NAFLD, non-alcoholic fatty liver disease, hepatitis B or HIV, receiving immunosuppressive therapy, and an independent factor is having diabetes. So having diabetes increases your risk of developing cirrhosis and the decompensated cirrhosis when you have hepatitis C. So this is Dr. Pai usually gives this talk, and I'm not going to give this talk, but this is just to remind you that hepatitis C is a systemic disease and it affects multiple organs. But one of the most common extrahepatic manifestations is the development of diabetes. It's diabetes. And most of these syndromes are not clinically recognized, and you really have to go and look for them unless they're very overtly obvious. So what is the connection between diabetes and liver disease? So diabetes can aggravate a pre-existing liver disease of any cause because it causes, diabetes causes inflammation, and that inflammation can lead to fibrosis in patients who have diabetes. And also it's an independent risk factor or predictor of liver decompensation on patients who have cirrhosis. So it is a risk factor for chronic liver disease by itself. On the other hand, liver disease can aggravate diabetes. So it's a kind of a catch-22 situation. And this is denominated hepatogenous diabetes. People with cirrhosis can, and I'm talking cirrhosis in general, not with hepatitis C in particular, can develop diabetes. And clinically overt diabetes is present in 30% of the patients with liver cirrhosis. And the majority of them have, if you do insulin resistance testing, they have impaired glucose metabolism. And the prevalence of diabetes is significantly higher if the patient has cirrhosis due to hepatitis C in particular. So it's not only that cirrhosis can promote diabetes, but if your cirrhosis is due to hepatitis C, the risk is even higher. And some studies, or many studies, have noted 2 to 10-fold increase in type 2 diabetes in patients with chronic hepatitis C compared to patients who have other chronic liver diseases. So this is a little bit more information on that chronic hepatitis C can induce or aggravate diabetes. And I've already kind of mentioned these associations, so I won't spend a lot of time on this slide, but you have it for reference. So what is the biological plausibility that hepatitis C, the virus itself, can have anything to do with generating or inducing or aggravating diabetes? So this is I'm going to show you a few slides of pathogenesis. So insulin binds to the insulin receptor, and that triggers the activation of protein kinase, which is called protein kinase B. That protein kinase makes the glucose transporter 4, which is a protein, go towards the cell membrane, and that is like a little tunnel that allows the glucose to come into the cell. So this is what normally occurs. So when someone gets infected with with hepatitis C, there's several mechanisms. The first thing is that there's an increase in tumor necrosis factor alpha and an increase in a molecule called suppressor of cytokine signaling 3. TNF by itself can promote, the slide is backwards, but TNF can promote steatosis, and it also blocks this the insulin receptor substrate, so the protein kinase cannot be activated. So it blocks the pathway right here, So this last path of activating the protein kinase will not stimulate the glucose transporter to go to the membrane. So glucose cannot go into the cell. And that's how insulin resistance is created. But on the other hand, TNF, as I mentioned, produces hepatic steatosis, and hepatic steatosis can induce fibrogenesis in the liver. I don't have a slide to show you the stellate cell, and I just remembered it now, but the stellate cell is a cell in the liver that anything that is noxious to that cell, which could be alcohol or viruses like Hep B or Hep C, or or fatty liver steatosis, it makes that stellate cell produce fibrinous tissue, and that's how the liver responds to those stimuli. And the end game is you have liver fibrosis. So when you go and research the literature of outcomes of hepatitis C treatment on diabetes, it's really extensive, and many of the papers contradict each other. But there was and I recommend, if you have time to read this, in Journal of Clinical Medicine of last year, they did a systematic review of all the papers. And in this slide, I just condensed the results of many questions that we have regarding the interaction of hepatitis C and diabetes. So the first question is, does sustained virological response achieved by direct antiviral agents like Epclusa or Mavoride, or the ones that we treat patients with, significantly prevent the onset of insulin resistance and diabetes? And in multiple studies on this systematic review of the literature, the observation was confirmed by most studies conducted on patients who were treated with antivirals. And there is a beneficial effect of curing a patient from hepatitis C and the development of insulin resistance or diabetes. But the problem is that we don't know how long this effect lasts, if it's only for a few weeks, months, or a few years, or if it lasts for a longer time. That has not been elucidated. The other question is, does hepatitis C clearance with antiviral treatment lead to a significant improvement of the diabetes control? And you have heard us in these meetings mention, if a patient's on insulin and you're treating their hepatitis C, be careful because their diabetes may improve. So in some groups, in some groups that published their results, there is an improved glycometabolic control at the end of therapy. But again, it's not known how long that will last. Now, the third question was very similar. We do recommend that while you're treating patients which have diabetes and hepatitis C, especially if these patients are receiving hypoglycemic agents like insulin or glyburide or sulfonylureas, you control their glucose levels carefully because they can develop hypoglycemia. The fourth question is, do direct antiviral agents induce glycemic changes that will have an impact on diabetes complications? And we know from these studies that when you treat patients with DAAs and who are diabetic, they have significant reductions in mortality from any cause, not only from liver disease. But this is not known if it's a direct effect of eliminating the virus, or this has some other, it's a surrogate marker for some other effect that these drugs can have. And finally, what is the clinical impact of DAA-induced sustained virological response on the incidence of liver cancer in patients with diabetes? And the conclusion is that most likely the magnitude of risk reduction in liver cancer incidence that was found among diabetic patients is probably comparable to that observed in non-diabetic patients. So we know diabetes has an increase in liver cancer in patients who have cirrhosis, but the treatment is not really related to if they have diabetes or not, the effect of curing their hepatitis C. So risk factors of occurrence or recurrence of liver cancer after you cleared the virus once you treat your patients. You can see here are all the risk factors, and one of them is diabetes. So if a patient's diabetes and you cure their hepatitis C and they have cirrhosis, they are still at high risk, lower than before, but still at higher risk of developing liver cancer than someone who does not have diabetes and cirrhosis. So in summary, chronic hepatitis C, with or without cirrhosis, can lead to or worsen diabetes. Achieving a sustained virological response can prevent or improve diabetes in many aspects. What we don't know is how long these effects last. And achieving sustained virological response can also reduce the complications for people with diabetes. Now, this is unclear if it's due to improving the glycemic effect or because hepatitis C also has other extrahepatic manifestations beyond diabetes, and that by improving those, the overall outcome of these patients are improved. And any patient with cirrhosis and diabetes, we still need to continue doing liver cancer surveillance. So my impression is that on diabetic patients that we treat their hepatitis C, sometimes there's an overt fatty liver that's left there, like a hepatic steatosis, not produced by the virus. And that is what's going to drive many of the higher liver complications patients with diabetes and hep C have, despite the fact that you cure their hep C. Sometimes it's very obvious. When it's not so obvious, it's those patients that they have advanced liver fibrosis, and it's very difficult to know what's still left inside that liver regarding steatosis or not. But having said that, on our next didactic, I will discuss evaluation of fatty liver, not hep C related, in general. And we'll see what we can do with these patients. Let's say you treat their hep C, they're cured of their hep C, but there still is a suspicion of fatty liver. How do you work them up, and how do you approach treatment? I'll give you a little spoiler. Yet we don't have a lot of medications to treat fatty liver, but we have some interventions. We have diet and weight loss. We have pioglitazone for the patients who are diabetic, and we have vitamin E for those who are not diabetic. But in the pipeline, there's tons of medications that probably are going to be available soon for treating fatty liver and NASH, specifically NASH. And I think as primary care providers, which most of you are, you should be prepared to evaluate and treat fatty liver in your patients, because it's going to be like, well, you already know it's a problem because you see it, but now we're going to have more effective treatments. And the key will be to know who you need to treat and who you do not need to treat, and who you need to get a liver biopsy and who you do not need a liver biopsy. And we'll try to tease those things out on our next didactic.